So using quality and other metrics, several organizations have wanted to talk about this value framework. So they bring to the table the possibilities and the cost associated with the care of myeloma. And, different groups have tried to tackle this: ASCO, NCCN, and most recently the Institute for Clinical and Economic Research, ICER. And these frameworks are incredibly limited. They almost never consider patient preference or patient heterogeneity. They almost never consider biologic heterogeneity, and that's something you and I do every day in the practice, for instance, with high-risk patients or not. And I had the duty to understand better ICER, so I did watch the 6-hour video of the ICER meeting. This was held in St. Louis, Missouri. I have to say that it's very clear, both from the comments as well as from the letters that were submitted to this meeting, that there was no significant stakeholder input. Patient support organizations such as the MMRF wanted to make it clear that they did not participate in the process. And while they had 2 myeloma experts in the panel, it was just for additional comment, but it was really not a substantial part of the process. And I think this created a lot of concerns for people who thought and who still think that there could be a situation where a proposal or a project or a report such as is created by ICER could be used by payers, be that private payers or governmental payers, to deny treatments. Now, let me give you a couple of examples of how bad this went. First of all, the ICER group concluded that perhaps the best value for medications would be for panobinostat. And all of us know that panobinostat is probably one of the last drugs we would consider using in myeloma. In fact, if we had to give up a drug, I would give up panobinostat in a second. Panobinostat has not had penetration in the market, and physicians have voted with their feet. In fact, this is so clear that the company has discontinued promotional efforts for panobinostat, which is sad because this is a true bench-to-bedside story. It came from the work from the laboratory of Dr. Anderson, where they understood clearly that HDACs could help in patients being treated with bortezomib. There was a properly designed phase 3 trial. The trial is positive, but guess what? The magnitude is not such that makes panobinostat rise to the top. So panobinostat is not one of the greatest values for the myeloma community, and that was the conclusion by ICER. The second one, which was problematic, is that they first gauge the value of the clinical data that is presented, and then they talk about whether there is value in how those medications are considered to be used in the clinic. And just before the voting, one of the members of the panel raises his hand and states, "Listen, I'm going to tell you that no matter what you tell me, no matter how effective these drugs appear to be or how safe they appear to be, I'm going to be greatly biased to vote for them as being of lower value, because I think that these medications are too expensive and that we would be better off as a society spending this money in roads and schools, etc." So the opinion is, of course, respectable. It's a fundamental philosophical difference. Someone who doesn't think we should be paying for cancer drugs. I understand that part. But that person should not be voting in the panel. And it is so obvious that if you just flip that 180 degrees and you had a member from a pharmaceutical company sit in that panel and raise a hand and say, "Listen, no matter how toxic or ineffective these medications are, I'm just going to vote they're of high value because I think that we should invest all the money in drugs," then we would discredit that as not a credible panel, and we just saw the exact opposite. So there's a lot of challenges, and I would urge individuals to take this with a big grain of salt. Now, I am concerned about this because the VA has indicated that they're willing to consider ICER-based reports for coverage determinations.